Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. The case is the one I'm going to share it with you. It's some sort of discussion generated rather than the complexity. It's part of our daily practice to see this kind of cases. This is a 70-year-old gentleman who had multiple medical comorbidities, and he had PCI in the past. With restenosis in the stents, and he presented again with acute coronary syndrome, and then had the workup, the non-invasive, plus his symptoms to confirm the relation of the symptoms to his presentation and the extent of the ischemia he had. And the coronary angiogram done plus the imaging to confirm this one, to prepare him or to prepare the case for the heart team discussion. And this is his medications. He's on optimal medical therapy, and the non-invasive imaging results. And then the modest elevation of the troponins, and this is his coronary angiogram. He had stent in the past. The stent in the RCA is occluded, and the diffuse disease, as we see, and long stent. Has long left main with occluded or significant disease in the distal left main, confirmed also by IFAS, and also the physiology as well, the significance of the disease. And we see the long stent. The stent in the circ is good. Stent on the ladies proximally is severe stenosis. So it's a combination of physiology, symptoms, anatomy by the luminogram and the IFAS. And then this is his results. And then we enforce the new modalities of since the imaging encouraged now by the guidelines to have it for the diagnosis and for the to support the intervention. And this is the results of the investigations done, the IFAS, conventional pressure wire, then the quantitative image, which will be the focus for the artificial intelligence in the future, and the result is consistent. All together confirms the severity of the left main disease, and this is the quantitative image, which combines the anatomy and also the automated QCA of the vessel and the physiology. As we see in the reading in the LAD is significant, but the LAD is interrupted by the branches. The presence of branches affects the physiological assessment of unless you have a straight segment of the QFR. But the circ, because it is straight away, so they gave us the accurate results of 75. Then the case discussed in the heart team meeting, and the consensus was for CABG. And the surgeon accepted the patient, and they went to the patient and they discussed with him in details, but the patient again refused surgery. So after the extensive discussion with the patients and exploring to him the cons and pros of the therapy, then he requested the alternative other than the surgery, which we believe it's not going to give him the result of surgery, but at least to relieve his symptoms and quality of life, but no mortality, as we know from the studies. What the best approach for this patient? So we started with the RCA, and our plan for the RCA is NC balloon, followed by the plus minus the IPL in case if we need it, plus the drug-coated balloon. And we achieved a good result with this one. And the RCA, as we expected, this diffuse nature, the fizzle is prone distally because of the extensive, as usual, the diabetic patients. So we accepted this result. And we went to the lift system, so pre-dilated with the NC balloon, followed by the IVL. And then we take the stent to the LAD to the left main. And this is the result of the LAD left main. It's acceptable. We did not touch the circ either with balloons or anything, just with the concentrated in the LAD left main. Because to make it simple, since he had extensive stenting in the past, diffuse nature, and we repeated the QFR again. So it's the quantitative, the image plus the physiology combination, and also gave us, we repeated the study pre and post intervention, and the result as we see. So it emphasizes the role of the use of the different modalities of the imaging to support the diagnosis and also the optimize the therapy for the intervention. And thank you.